Hi, my name is Kelsey Duncan. I'm the staff pharmacist today, and I'll be presenting our patient. Our patient's name is Margaret Thompson. She is a 27-year-old African-American female whose chief complaint is increased asthma symptoms. She has a history of mild persistent asthma and generalized motor seizures controlled on topiramate. She complains of increased asthma symptoms but does not appear in acute distress. She states she has daytime symptoms approximately 3 times per week and uses her rescue inhaler 3 to 4 times per week, but not usually multiple times in a day, and is awakened by her symptoms approximately 1 time per week. Her symptoms are not tied to exertion alone, and she states good compliance to asthma medications and demonstrates proper inhaler techniques. The patient is wondering if her change in her asthma medications is needed. Her past medical history includes mild persistent asthma for about a year on maintenance and rescue inhaler. She has generalized motor seizures, about 2 per month, and she's stable with topiramate. She has no pertinent family history to this case. She denies any recent alcohol use. She's a former smoker who quit about 3 years ago, and her insurance is through Blue Cross Blue Shield. She has an allergy to gabapentin. It causes edema. Her current medications are topiramate 100 milligram tablet by mouth twice daily, Trisprintec once daily, fluticasone propionate 0.044 micrograms per actuation meter dose inhaler, 2 puffs twice a day, and albuterol 0.09 micrograms actuation meter dose inhaler, 2 puffs as needed every 4 hours. She is currently up to date on all of her vaccinations, and she had her flu shot in January of this year. The physical findings is that she was lethargic, found increased asthma symptoms per her history of present illness, but no acute distress presently, intermittent insomnia, and mild wheezing. Her blood pressure is 110/72. Her heart rate is 90 beats per minute. Her temperature is 98.2 degrees Fahrenheit. Her respirations per minute is 18. Her height is 69 inches, and her weight is 158 pounds. And her BMI is 23.3 kilograms per meter squared. All pertinent labs were within normal limits, and her creatinine clearance was 120 milliliters per minute. The problem in this case is uncontrolled asthma. Our evidence of this problem and our rationale is the patient was diagnosed with asthma in June of 2019. The patient is uncontrolled on her current medication regimen of Flovent, which is an ICS, and Ventolin, which is a SABA, which is step 2 of therapy in the GINA Pocket Guide. Our patient's current level of asthma symptom control per the GINA Pocket Guide was a 3 out of 4, which indicates that her asthma is currently uncontrolled, and these 3 were daytime symptoms more than twice per week, night waking due to asthma, and reliever needed more than twice per week. We are needing to go a step up in therapy to step 3 with a low dose ICS LABA such as Symbicort, and we can also use the Symbicort as her reliever inhaler. So our goals are to relieve and control symptoms of asthma, and they can be seen as controlled with decreased need or use with the reliever inhaler, decrease night waking, and decrease her daytime symptoms. So we will be using Symbicort as her controller and reliever, and we will be discontinuing the Flovent and the Ventolin. So for her controller, it will be Symbicort 80 micrograms / 4.5 micrograms, 2 puffs by mouth, twice a day, indefinitely. And then for the reliever, it will be also 80 micrograms / 4.5 micrograms, but 1 puff by mouth as needed, indefinitely. The safety monitoring for this medication will be to rinse her mouth out, to swish and spit to prevent thrush in the mouth, and the medication could also cause headaches. And we would like the patient to follow up in 1 to 2 months to evaluate improvement of symptoms. If the symptoms remain uncontrolled after 3 months, the dose can be increased. Do you have any questions? Thank you.